Thank you very much. Good morning, everyone, and welcome back to day 2 of the 186th meeting of the NICHD Advisory Council. I did want to point out something about the microphones. These microphones are different from the ones we were using yesterday. So now you want to see the green signal if you're speaking and then turn it off after you're done. Today, we're going to hear a very special report from a new council working group that was formed recently, very recently, in fact, in August, on necrotizing enterocolitis, also known as NEC, in premature infants. We established this group last month in response to a United States Department of Health and Human Services request to develop a summary of the state of the science and recommendations for future areas of research. The co-chairs, Dr. Bonnie Maldonado and Dr. Ravi Patel, who's not a council member, but a neonatologist, as you'll hear, will present the results of the group's intensive work over the past several weeks. And we're very grateful to them and to the NICHD staff, and especially to our Deputy Director, Dr. Allison Cernich, who pulled all this together in a very short time. The council members know Dr. Bonnie Maldonado, who serves as the Tobey Professor of Global Health and Infectious Diseases at Stanford University, where she is also Senior Associate Dean, Faculty Development and Diversity. She's Professor of Pediatrics and Infectious Diseases and of Epidemiology and Population Health. Dr. Maldonado directs Stanford's Global Child Health Program and serves as the Medical Director of Infection Prevention and Control at the Lucile Packard Children's Hospital. She's currently serving as the interim chair. She doesn't have enough to do. So now she's currently serving as the interim chair of the Department of Medicine and leads a research program on epidemiologic aspects of viral vaccine development and prevention of perinatal HIV transmission. On video, we're grateful, Dr. Patel, for you joining us. We've got Dr. Ravi Patel, who's a neonatologist at Children's Healthcare of Atlanta. He's professor of pediatrics at the Emory School of Medicine, where he directs a research program on, number 1, necrotizing enterocolitis, including its relationship with neonatal transfusion practices. Number 2, caffeine therapy in preterm infants. Dr. Patel received his medical degree from Medical College of Georgia at Augusta University, followed by a Master's of Science in Clinical Research and fellowship training in neonatology at the Emory University School of Medicine. So they are going to make their presentations. I'd also like to acknowledge David Rowich, a member of our advisory council, served as a member of this working group. So over to Drs. Maldonado and Patel, who moved mountains in a matter of a few short weeks, and we are very grateful to you.
Thank you, Diane. And I want to thank my co-chair, Dr. Patel, as well for his expertise in this area of necrotizing enterocolitis. So, as you heard, we were asked to...
Bonnie, we need to turn on your microphone.
Oh, okay. All right, I'll lean over. So we were at, can you hear me? Yeah. Hello? Great. Yeah. Okay. So as again, I want to thank my co-chair, Dr. Ravi Patel, and also want to thank the NIH staff who really expedited and put this program together very rapidly. They did a really amazing job at pulling together a large group of subject matter experts, and you'll see more about that. Can you hear me here? No? Well, we'd like to. Oh, sorry. Sure. Great. Is that better? Yes. Yeah, okay. Thank you. So we as you can see here, the charge in August of 2024, at the request of the Secretary of the Department of Health and Human Services, NICHD convened a necrotizing enterocolitis in preterm infants working group of the National Advisory Council of Child Health and Human Development. Next slide, please. So the specific charge to the working group included the following. We were to assess the scientific evidence regarding the enteral feeding practices in premature infants and factors that may protect against or increase the risk for necrotizing enterocolitis. We were asked to identify important research gaps and to make recommendations for potential future research directions. Now, the actual process itself was fairly rapid, but it was quite thorough considering the time frame. The group was composed of subject matters in necrotizing enterocolitis, including laboratory scientists and neonatologists, as well as advocacy leaders. As you can see here, the group met 3 times over the last 3 weeks on August 15th, 22nd, and 28th. As part of the state of the science analysis, NICHD conducted as well a portfolio review. And you can see there for grants issued in the last 5 years from fiscal year 2018 to 2023. And as you can see, they identified over $101 million in NIH funding related to necrotizing enterocolitis. I'm going to call it NEC for now, just for ease of speaking, including over 340 unique projects, 100 unique PIs, and 60 unique institutions, with 44% of those funds coming from NICHD, including clinical trials, 24% from NIDDK, including many mechanistic studies, 40% overall focus primarily on NEC versus NEC as a secondary aim or outcome. So about 3/4 included research project grants, 10% were SBIR STTRs, and 9% were cooperative agreements. Next slide, please. So the NEC working group activities included the following. We reviewed the state of the science for risk factors for NEC, nutritional support for preterm infants, and association between feeding practices and risk or severity of NEC. We then developed recommendations to improve the evidence base. Next slide, please. So as many of you may be aware, necrotizing enterocolitis is a common serious gastrointestinal illness in which the tissue lining in the intestines become inflamed, die, and can slough off. Symptoms include bloating or swelling of the abdomen, bloody stool, bile in the stomach, and food not moving through the intestines. One of the leading causes of illness and death in preterm infants, it occurs primarily in infants born before 28 weeks gestational age, with one infant dying almost every day from NEC in the United States, with approximately 356 deaths recorded in 2022, according to CDC data. NEC can appear suddenly and progress quickly in infants who otherwise may seem to be getting healthier. Next slide, please. Factors that may be associated with risk for NEC include maternal antenatal factors, factors related to mother's pregnancy, health and treatment, and the infant's characteristics and treatment. Factors that appear to increase risk include maternal preeclampsia and hypertension, and very low birth weight or small for gestational age infants. And factors that appear to be protective include maternal antenatal corticosteroid use or tocolysis treatment and exposure to human milk. So next slide, please. So the following assessment is of the quality of the research evidence and does not represent clinical guidance. Please refer to practice organizations for specific clinical management recommendations. And at this time, I'm going to turn over the discussion to my co-chair, Dr. Ravi Patel. Thank you.
Thank you, Dr. Maldonado, and good morning to everyone there. We're going to start with some foundational starting points that the working group began with and acknowledge these concepts that all babies must be fed as soon as medically feasible, and that nutrition is vital to the continued development of the infant's brain and other organs, and that prolonged fasting can increase the risk of serious conditions in these tiny babies. And that feeding should be done by whatever means is available. However, intravenous feeding can increase the risk of developing bloodstream infections. The American Academy of Pediatrics recommends that very low birth weight infants, those are infants less than 1,500 grams, receive human milk, preferably from their own parent. If this is not available or insufficient, then pasteurized donor human milk is recommended. And for early preemies, human milk often needs to be fortified to meet their nutritional needs. And so these were some of the kind of shared starting points that the work group began with. In terms of enteral nutrition, which can be provided either by mouth or by a feeding tube, and its relation to NEC, there have been a number of studies for many years. We started by looking at different approaches to feeding and looking at how soon or to start feeding or how quickly to increase feeding, and clinical trials of different approaches for initiation or advancement of feeding have shown no clear effects on the risk of developing NEC. Next slide. Now, when we looked at base diets and research as part of the working group's charge on which base diet to feed early preterm infants, when the parent's own milk is insufficient or unavailable, giving donor milk can lower the risk of NEC. And recent clinical trials have focused on either very low birth weight or extremely low birth weight infant populations. Those are infants less than 1,500 grams at birth or less than 1,000 grams at birth. Now, human milk sometimes needs to be fortified to meet the nutritional needs of preterm infants. And so research on how to fortify the base diet by adding specific components has shown mixed results on whether to use human milk or bovine milk-based fortifiers. These clinical trials have tended to be small with too few cases of NEC to draw firm conclusions. Next slide. Based on the experience of the experts in the working group and the presentations, the working group identified several limitations of the existing evidence on NEC. One limitation was that other intestinal conditions may mimic NEC, which can limit some of the surveillance evidence for NEC. For example, ICD codes may include both NEC and a separate entity, spontaneous or focal intestinal perforation, in the same code. Additionally, much of the evidence shows associations, not direct or indirect causation. There needs to be a link to the associated clinical risk factors for development and or progression of NEC with biological pathways for the underlying mechanisms. And some of the risk factors identified in observational data have not been confirmed in clinical trials. For example, red cell transfusion and empiric use of antibiotic treatment with ongoing clinical trials currently. Additionally, many of the existing studies have been small in size with too few NEC cases to draw firm conclusions. Next slide. Now, as the working group worked to generate recommendations to council, and so I'm going to go over some of the recommendations. These are research recommendations from the working group. We had three overarching recommendations. The first, and obviously the best way to prevent most NEC cases is to prevent preterm birth. And therefore, the group recommended the continuation and expansion of research into ways to prevent preterm birth. Second, the working group felt that we needed to develop a more specific definition of NEC and the severity of NEC to improve epidemiologic studies and also to improve determination of eligibility for clinical trials and treatments and endpoints. Third, as part of the research process, we need to understand and include the perspectives of affected families. How can we inform them better about the risks of NEC? And how can we support them during the time in the neonatal intensive care unit? Next slide. Related to the epidemiology of NEC, the working group recommended that we improve the tracking and reporting of NEC cases, as well as deaths from NEC, to better quantify the total burden of disease. And that this needs to be done using newer ICD-10 codes for NEC and also by stratification by the gestational age of birth to understand the impact on different populations of preterm infants or more mature infants. Additionally, the working group recommended expanding support for neonatal biorepositories that collect, store, and share NEC biospecimens for research, and that this could allow identification of diagnostic, prognostic, predictive susceptibility, and/or surrogate markers for NEC. Next slide. In addition, research needs to explore innovative methods for collecting and analyzing data. For example, can data be used to provide estimates for factors that contribute the most to the risk for development of NEC or the progression of NEC? What's the attributable proportion of disease related to specific exposures, such as nutritional approaches or baseline characteristics? And how accurate are the diagnosis rates for NEC? Additionally, what treatments have the most beneficial outcomes? And can artificial intelligence or machine learning be used to look at electronic health records or routinely collected data of babies with and without NEC to improve the diagnostic criteria? Finally, are there biomarkers or surrogate measures that can help in studying NEC given its relative low incidence? In terms of mechanisms, the group listened and discussed several presentations about the underlying biologic mechanisms of NEC. We recommend expanding research support into the mechanisms of NEC development. We need biomarkers to improve early diagnosis of NEC and to enable earlier treatment for NEC before the disease progresses. And understanding and knowing more about the underlying mechanisms of the disease will help us to identify potential prevention and treatment targets, including knowing more about the genetic and epigenetic pathways of NEC. We need additional laboratory and animal models to better match the disease complexity in laboratory experiments. The field has developed NEC in a dish and NEC on a chip models, and animal models, mainly in mice, rats, and pigs, have been utilized. And gastrointestinal organoid systems are being developed and being used. And these models need to be expanded to include the multifactorial complexities of the disease. Next slide. Moving on to the factors affecting the risk of NEC, the working group recommended exploring exposures that may be positively or negatively associated with the risk of NEC development, severity, mortality, the emphasis on specific nutritional components, the use of antenatal and postnatal antibiotics, and the impact of gut bacterial dysbiosis or viral infection on the risk of NEC. Additionally, expanding research on feeding practices that may affect the risk of NEC, and this would include when to start and how fast to increase feedings in very low birth weight infants, and what components of human milk, fortifiers, and/or formula are most beneficial. Related to nutritional support, the working group recommended supporting research to identify the optimal nutritional needs of premature infants. What do these infants really need to thrive? Increasing research on how to help parents increase their milk production and improve lactation techniques. This research would be beneficial not only to early preterm infants, but really to all preterm and term infants broadly. And supporting research that determine how to improve the safety of human milk, particularly donor milk, by collection, processing, storage, and dispensing. And to better understand what are the bioactive components of human milk that may be protective for NEC, and how can we preserve these while still protecting against the infectious risks that may be present in donated milk. And to develop point-of-care diagnostic measures to measure milk components in NICUs and/or in donor milk banks. And also research potential standards to guide standards for donor milk. For example, the optimal postpartum timing of donation of milk, milk composition, approaches to pooling of donor milk, and optimization of donor milk for specific populations, such as very low birth weight infants. Related to the evidence about different feeding practices and the risk of development of NEC, the working group recommends to the Secretary that we support large, independent comparative effectiveness clinical trials of feeding practices and NEC risk. Because NEC is a relatively rare outcome, we need large trials to have enough power to definitively answer questions about feeding practices. This would include evaluation of different types of fortifiers and methods of fortification that are used to reduce the risk of NEC, as well as how and when to transition babies that are receiving donor milk off of donor milk when the time comes. As part of that, we need to develop innovative clinical trials that can test the safety and efficacy of promising nutritional additives to prevent and/or treat NEC. For example, probiotics that show promise, we need ways to develop and manufacture these products consistently so that they can be tested and evaluated in neonates. We need to find ways to test multiple components together. We may find that we need more than one ingredient to optimize prevention and/or treatment for NEC. Finally, we recommend expanding implementation science research to reduce disparities in access to donor milk, for example, for very low birth weight infants in populations where this is recommended. Are there barriers to accessing donor milk in rural communities, hospitals, and/or in minority populations? And how can we better encourage and support breastfeeding and milk donation in affected groups? Currently, how can we improve lactation support for new mothers? And lastly, we need support on research on parent education. How can we best inform parents in the NICU about optimal feeding practices and the risk of preterm conditions such as NEC? The next steps for this working group are to finalize a report of our findings and recommendations and submit this report to the Secretary of Health and Human Services by September 16th of this year. And I wanted to finish by really thanking the working group members for their dedication and willingness to come together on such short notice, my co-chair, Dr. Maldonado, and really the incredible support from colleagues at NIH and NICHD on putting this and moving this process forward. So thank you to all that have been involved, and I think we have some time for questions and feedback.
Thank you, Drs. Patel and Maldonado, for such an informative report. Now is the chance for the council to provide further discussion. So the floor is open, and we really encourage your questions and additional thoughts because we will incorporate them into the report.
That was really excellent. Thank you both and the committee. Microphone. If it is on, maybe I just wasn't looking at it. Closer. But I had a question. Maybe this is it's green.
Maybe closer. Yeah.
So this is probably reflects my own ignorance and maybe seems simplistic, and maybe it's been done, but if human milk is best, have people, whether it's, some separation technique, HPLC, whatever it is, has somebody looked at human milk versus formula to see what it is that's either good in human milk or bad in formula, so that you can be, when human milk is not available, have a better alternative? Do we know why human milk is good?
Yeah, I can take that. That's a good question. There were specific presentations by as part of this working group specifically on that important question. There are a number of factors that were reviewed that are protective in human milk, including human milk oligosaccharides, epidermal growth factor, lactoferrin, and a number of other components that may explain the beneficial effects on intestinal health, intestinal maturation, and so those are things that have been looked at, and it may be that the absence of those factors or the lack of those beneficial factors might influence the risk of kind of some of the risk that's attributable to NEC as it relates to feeding practices. And I don't know if Dr. Maldonado has anything she'd like to add.
No, we had a series of experts who did come in and talk to us about all of the different components and studies in vitro and in vivo looking at individual components, but taken together, there's still a dearth of information about which factors really are promoting gut health, nutrition, et cetera. So I think there are some individual components that Dr. Patel mentioned and others, but it's not clear which ones are best in human milk and what's missing in formula milk, or is formula actually, does formula have components that are detrimental? So that's still not clear.
But I didn't see that as a recommended research area, which seems like that would be very fruitful, to either find out what's bad in formula or find out what's good in human milk. Seems like that would be something that would be important to do, because you may end up having to create some alternative, but without knowing what ingredients you need, you're in trouble.
Yeah, so indirectly, I think one of the areas that we looked at is supporting research to identify the optimal nutritional needs of premature infants. And then the other area was looking at specific models, for example, NEC on a chip or NEC organoid type models. So trying to identify ways to pull apart those particular components.
Thank you. So we have a question online from Dr. Barkin, and then we'll go to Drs. Neil Perry and Yampy Bannerman.
Great. Thank you. Good morning, everybody. And thanks to Dr. Patel and Maldonado for this important work and the large team that supported you. Just two comments, and I think apropos of the first comment, we know the microbiome really makes a difference there, and we now have emerging technologies so we can ask and answer different questions to try to better articulate and identify what those elements are related to the microbiome. My question is, I'm really struck by the fact that only 356 children die a year of NEC, and every death is a tragedy. So 356 is still too large of a number. And yet, if you compare the number of neonates that have all of the risk factors that you all articulated to those who don't, those who have the same risk factors and don't get NEC versus those that do, there is a lot of good data to be found in those that don't get NEC. And I just wanted to understand if the committee pulled that forward to look at sort of the found pilots, the positive outliers, to learn from them as well. Thank you.
Well, I'll let Dr. Patel take the first first step in answering that, and then I have my own comments.
Sure, Pam, that's a great point. And we know that babies who, for example, receive only human milk still are at risk of NEC, and we don't understand why that is. And part of some of the recommendations about understanding the attributable proportion of disease, what are the factors that we understand that can explain NEC, and maybe there's some residual uncertainty. And I think trying to understand why is that even in infants who seemingly may not have some of those risk factors that develop it or experience those, I think that there's opportunity to better understand that, because it is relatively uncommon when you think of the very low birth weight population and overall incidence. And to the point about the microbiome, that was an important part of one of the recommendations on understanding bacterial dysbiosis as well as viral infections. Those have been associated with kind of an imbalance and abundance of specific types of intestinal bacteria, like proteobacteria, have been associated with the risk. And it's still not clear what's driving that change in the microbiome, and I think opportunities to better understand that.
Okay, so Dr. Barkin, to your point, we've talked about this from an epidemiologic perspective as well. So given the almost 4 million births a year, we think that there are about almost 60,000 premature births, and among those, the highest risks are the very low birth weight infants. And the question would be then, the mortality that you see is really, as you mentioned, the tip of the iceberg. But what is the form? Are there form proofs of NEC? Is there a progression of disease? And what happens to children in the intensive care nursery, for example, that are put on NEC prophylaxis or NEC preventative measures? And what are those factors, and how do they compare to, say, the children who ultimately develop full-blown disease and or die? And how can we pull out any of those variables and understand that? So that was one of the recommendations, is understanding more about the prevalence of disease overall, looking at endpoints, and then finally looking at, say, deep dives into electronic health records to try to understand the bigger denominator of children who may have some earlier versions of this and how they might be different, for example, from the children who ultimately succumb to the disease.
And I really like this notion, which is we're probably underdiagnosing many different phenotypes of NEC. So I think that's such an important recommendation. I just would encourage the committee to also really pull out as a recommendation, understanding children who have the same risk factors but don't go on to have NEC. That's a really rich group to learn from as well. Thank you.
Thank you.
Can you hear me? Okay. Well, actually, Sherry actually asked some of the questions that I had. The other thing I guess I would add to that is one of the things that you identify as a protective factor is steroids, and just understanding a little bit more about how steroids actually may modify the gut microbiome and why that's protective, because one would think that steroids, do specific things to the gut microbiome. And this is a separate question, but do you have any long-term health outcomes for kids who did not quite get full-blown NEC, but have had some very serious illness in terms of what their health status has been as they've developed? Are they at increased risk for other diseases?
Okay, so the first question was about corticosteroid use and risk. And then the second question was children who...
Just understanding the life course of children who did not have full-blown NEC, but they had been sick and hospitalized for a long time. Do you know whether they're at any increased risk for other disorders in life?
Right. I don't know, Robbie, do you want to take the first
Yeah,
question?
yeah. In terms of NNL steroid, the first question, NNL steroid administration, particularly in the early preterm infants, has a number of effects broadly in terms of improvement in survival, reduction in bleeding, and just broad maturational effects on the lungs and the gut, and that likely explains some of the broad health benefits in the preterm infant in terms of reduction in a number of outcomes, including NEC. In terms of long-term outcomes, most of the studies have focused on 2-year outcomes. We have very little looking beyond 2 years, although there have been some. And most, to your point, have focused on those infants who have more significant disease, such as surgery for required surgery, where we know there's a substantial long-term burden of disease. I think we know less about the milder cases, those infants who might be medically managed and recover without need for surgery, and what the impact of that is. But we've heard from families and survivors who are even in adulthood that develop NEC and some of the long-lasting effects of the disease. But I think an area that wasn't specifically called out, but because it's maybe less specific to enteral feeding, but I think an important area for understanding.
Can you all hear me okay? Thank you for the lovely presentation and for covering this important topic in such a short time. I was particularly enthused that you called out preterm birth and that one of the primary, I think it was your first bullet in a way to prevent NEC, would be to identify strategies to prevent preterm birth. As I think many folks know, the primary preventative strategy we've used for over 20 years in maternal fetal medicine was recently pulled from the market, and with nothing to replace it. I think there's an urgent need for us to identify strategies to prevent preterm birth. In fact, coming up at SMFM early next year, the President's Workshop is going to be on preterm birth prevention because there's been seemingly a pause in our strategies and a pause in the research. And I think we need to reinvigorate ourselves to really focus on preterm birth and try to figure out how to prevent that. So thank you all for calling that out. I think, if the working group continues to move forward, it would be great to have maybe more of a representation of maternal fetal medicine docs and obstetricians to kind of help with that strategy, just because it was the number one strategy you called out. So really thank you for focusing on that. Appreciate it.
So I was actually impressed by how much current funding is going into NEC. And I'm trying to understand, of that funding, how much of that actually may be addressing some of these areas that you want to enhance, and how much is really lacking.
Yeah, that's a good point. Regarding the $101 million that are currently being utilized, we didn't have a chance to really look at the portfolio, but that would be something that we could take a look at before our final report to the Secretary to understand what areas are already being addressed. Great point.
And also, are there premature cohorts that could easily be pivoted to try to enhance their funding, to develop an arm that would address these issues on NEC?
Robbie, do you know of any existing premature cohorts or cohorts that are enrolling infants at risk for?
There's ongoing work by groups looking at it, kind of developing a biorepository across a kind of select number of centers led by one of the presenters of the working group, Misty Good. There are kind of the NEC Research Network enrolls a number of cohorts that involve the most immature infants and collects epidemiologic data routinely on those across 15 participating centers. That's part of NICHD across the U.S. that do collect, but that cohort is, I think, more broad and could be enhanced with more specific measures if that was a process that went forward.
Thank you for this great presentation and the work. My question is related to the impact of co-occurring other morbidities that affect preterm infants and how those are treated and the impact of that on NEC. How will that be integrated in your recommendations?
Yeah, Ravi, that's a great comment around what are cofactors and what do we know about the cofactors. One of the areas just that we discussed in particularly one of the meetings.
Dr. Maldonado, I think we lost your audio.
Here? Yes. Can you hear me, Ravi? Yes.
Yep.
Okay. So just looking at attributable factors. So given underlying conditions, how much do they weigh in on risk for NEC? And I think that goes back to Dr. Barkin's question as well around what do kids have that develop NEC versus those who don't? So looking more deeply at that. I don't know, Ravi, if you have comments.
Yeah, there has been some work. Babies who develop particularly require surgery for NEC have a high risk of neurodevelopmental impairment, high risk of cerebral palsy, and that risk might be increasing. There has been work at understanding the mechanism of kind of gut injury related to brain and specific targets that might be opportunities for therapy. And there are a couple of groups that are working on those areas to try to minimize some of the NEC-associated morbidity among those that develop disease. Of course, the best way to prevent that morbidity is to prevent NEC or to reduce the severity initially. But once babies develop it or require surgery, I think there is some effort at trying to target some of the pathways that might be responsible for brain injury and cerebral palsy from the degree of gut injury and inflammation that goes on.
I had a question, actually, a scientific question. I was able to attend 2 of the 3 meetings, so maybe this was discussed in the 3rd. But as we know, there are maternal cells in breast milk, and they play a role in educating the infant's immune system. So did anybody bring up the issue of cells in breast milk and what could be the consequences of giving foreign cells in breast milk via the donor milk?
I don't recall it, that came up in the conversation. Do you recall it, Ravi, if that was addressed?
No, the cells specifically weren't talked about. There were discussions on kind of a human milk science aspect about specific variability in specific components of human milk, like DSNLT, which is a human milk oligosaccharide that's not present in all lactating people, and that amount or abundance of that specific component might vary in, for example, donated milk. So that was discussed, but not specifically cells. And on whether that's an impact or differential between donated milk and milk from a parent.
I will say one of the other areas that was really that's always been really striking about NEC is that it does have a fairly time-limited period of risk. So to the extent that there's an evolving gut, maybe with maternal cells, infant ontogenic issues around infant gut immunity, all of those factors seem to play a role in a very critical early period primarily in the preterm infant, but also in some cases in the term infant. So those are areas of interest as well.
I'm just trying to understand again a little bit more, because I think that goes back to Marcel's question about understanding kind of what's in maternal milk versus what's in formula, and just kind of trying to understand some of those differences as a way to help us identify factors. When using donor milk, do you see differences in terms of benefit? So if you're using frozen milk versus fresh milk, do you see differences?
Yeah, so and I'll let Ravi expand more, but so studies have demonstrated, so in studies where parents' milk versus donor milk versus formula, when there is a difference, there's a statistically significant difference between giving donor milk. So there's a benefit to donor milk compared to formula. I don't know, Ravi, if you have any further.
Yeah. There is, and there were some discussions and presentations on kind of the differences between parents' own milk and donor milk, because donor milk goes through pasteurization that alters some of the, for example, the milk microbiome gets changed, and there's some other components that are altered, and whereas others preserved. There's still, as Dr. Maldo mentioned, a protective effect in terms of freezing and processing that also might have some alterations that. There haven't, because our goal is for feeding a parent's own milk when that's possible. There's not been any clinical comparative trials or studies between donor milk or parent's own milk. Most of those have been if a parent's own milk is insufficient. There have been some microbiome studies comparing parent's own milk versus donor milk, and maybe some suggestion of potential differences, although I think just some limited research in that area about how they might impact that, but there are known changes that occur with pasteurization of donor milk compared to parents' own milk that have been evaluated and studied.
I think I wanted to comment on the same point. Just in the conversations on the calls, there was evidence presented that rates of NEC were approximately halved when you used human milk versus formula. So, I mean, that's a major insight into I guess pathogenesis by implication. It has practice implications, although the group wasn't supposed to be talking about best practice. I think what hopefully will come across in the report is human milk is preferred. Parents' own milk, I guess, is number one, or donor milk. Donor milk access should be increased. And then the questions scientifically are, what is it about the human milk that is protective? And it really helps to frame where I think the further research could go, looking for those specific factors, cellular or biochemical, in even milk. But it was a very impressive set of data we heard from NICHD network and other human studies about just the benefits of human milk. So I came away with a much clearer understanding of the benefits.
I would say that maybe also just opportunity to understand how best to preserve human milk so that you have optimal effectiveness and benefit.
I think that discussion came up as well, and we tried to showcase it in one of the slides, but it became clear that the standardizing protocols for handling, storage, all of the operational elements that require banking of and distribution of donor milk are really not quite as well developed as one would like, and so that was an area of opportunity as well.
So we'll go to Inya and then Pepe.
I just have a short follow-up question on that, and that is the gestational age at the time of delivery when the donor milk is obtained is potentially much more advanced most of the time than the gestational age of the parent who provides the milk. So is that taken into account in studies to look at, is there a difference when you get human milk at 24, 25, or before 28 weeks and later on?
Yeah, Robbie, do you want to?
That was one of the presentations touched on that, which is the donors that provide donated milk vary in gestational age. Some are after delivery of an infant born at term, and so the nutritional content of that milk is different than, for example, the nutritional content of milk from a parent who might be immediately postpartum. And also some of the components do differ over the weeks and months postpartum in terms of the characteristics of the kind of donor milk. And there was some discussion about better understanding that to potentially optimize the delivery of donor milk that might maximize its kind of beneficial content of specific components by selection of donors within for example, a certain amount of months postpartum that might allow that, although that's an area where there still needs more data to kind of guide that aspect. But there are differences in donors, and those donors, many of them are born have delivered at term gestation, so the characteristics of that milk is going to be different than that for a baby who's born, for example, at 24 weeks gestation.
Yeah, the other issue that came up was the fact that there are really no point of care diagnostics for determining the composition of milk when it's given. So again, whether or not you can even try to match chronological and gestational age, even beyond that, is just understanding the content, even at the same chronological or gestational ages. There's a good degree of variability among donors, and it would be the different members of the working group thought that it would be helpful to have rapid diagnostics to be able to determine that content and the composition.
Okay, we'll take one last question.
Thank you. So one of the recommendations was on harnessing open-ended AI and machine learning, and that makes sense given the number of studies. But do you think, what's the readiness of the data sets? Do you think we need some harmonizing, or they need infrastructure that needs to be done before we go there? And my second question is, how would you prioritize all these recommendations, or do we need to?
Yeah, great point. I don't know, Robbie, if you have, we talked a bit, and I know with David Browich as well, we talked about the availability of electronic health records data sets. And I think that more and more they are becoming available in general. I don't know specifically for this particular indication, but that capacity is being built at a number of institutions. The question would be, again, the ability to have the computing power to be able to store that kind of information and the number of patients needed. So that's an important question. I don't know, Robbie, if you have other comments.
Routinely collected AHR data. I think there's opportunity. The challenge for a lot of the machine learning and AI models is training on what's the gold standard definition, and that's a limitation of kind of what do you use as a gold standard definition to learn on those models. The other challenge is NEC can be an acute disease that often is very sudden onset, and so the kind of documentation in routine EHRs for kind of the clinical symptomatology, for example, at the time of onset may not be consistent. And so some of the features that might be recorded on a daily basis, for example, a daily note, may not capture the granularity that might be needed at time of onset, which can be very acute and progress quickly. And so that might be, there are other data in the electronic health record that can be extracted, but some of the clinical data is limited in that regard.
Yeah, and then you also mentioned prioritizing. We couldn't get to that point yet. And I don't know if in the next week we'll be able to do that. It's a pretty broad array of questions, but I think we'll have to think about that, maybe a second set of meetings to try to think about prioritization. But I think this was at least a preliminary stab at some of the high level questions that haven't really been addressed.
Okay, in the interest of time, regretfully, I have to limit the discussion. And again, I want to thank everyone involved and the council members for their very interesting and relevant questions. We are now going to ask for a motion for approval of the working group's report. We're going to do double duty and ask you to endorse the recommendations for future research. So we'll use it also as an open clearance of the concept. So we need a motion to approve the working group's report and at the same time provide concept clearance. So does someone want to provide a motion?
So moved.
Thank you. Marcel, is there a seconder?
Second.
Thank you, Inya. Now we're going to ask you to vote by raising your hands, and those, I see Dr. Barkin. I don't know if Dr. Ainser and Dr. Fair.
Professor Brooks and Dr. Fair.
Okay. Okay, thank you very much. So the working group's report is approved. Again, we thank you for your outstanding work. At this time, the open session is going to conclude. We are going to take a 15-minute break now to switch over to the closed session. I realize some of you have tight flight connections, so we may need to sacrifice the break later on in the meeting. I'm very aware of the fact that people need to get to the airport. So let's take a break now, and we will resume at 10 o'clock.